Good morning, Steve Stites, Chief Medical Officer, University of Kansas Health System. I am here with my good friend Dana Hawkinson, Hawkeye.
Yes.
Welcome. We're back here in the studio, the Dulce Simons Family Studio at the University of Kansas Hospital, broadcasting live. On my left is another good friend, Doug Gaston, our CFO, who's going to be with us today to talk a little bit about the financial shape of hospitals and health systems, especially as we look at a second wave, another surge, where are we on the pandemic? And yeah, it just keeps coming, doesn't it? It just keeps coming. But before we go to those questions, Dana, how are we doing today?
It's not good.
I know it started going up. What happened?
We are not happy with that. I think what's happening is we are not in a surge. We are just in an expansion period right now of the virus in general. We were quite happy when the virus cases in the hospital had kind of dipped down after seeing a peak of 24 about 10 days ago, 2 weeks ago, dipped down to about 15. But really since that time now, and especially the past 4 or 5 days, we have seen climbing numbers. So right now in the hospital, we have 22 patients, 8 of those in the ICU and 2 of those on the ventilator. I myself, when I was on call this weekend, saw 4 new COVID patients. So unfortunately, we had heard that the hospitals around the city were having an increase in the number of cases. We were happy that we hadn't seen it. But right now, the past few days, it looks like we are on the uptick.
It's a slow trend. But
it is.
You know, these pictures from the Lake of the Ozarks that we've got, this is the same bar that people got focused a few weeks ago.
Yeah.
Now, they are outside. That's good. But still, not quite the degree of social distancing we would hope. And it's in that same sort of younger 20 to 30-year age range. And whereas folks who are 20 to 30 may stay relatively healthy, the problem is they take it to people who may not stay relatively healthy. And in fact, the 20 to 30-year-olds can be admitted too.
Yep, absolutely.
And there's this sense of invincibility, of invulnerability, but that's not really how COVID works.
No, absolutely. You know, I did see 1 or 2 of the younger patients, certainly younger than 40 this weekend. And we have to understand that even people that may have mild symptoms or no symptoms, we can find CT scan findings on their chest that they look like they have a pneumonia. They can still have problems afterwards, say after 2 weeks, of either fatigue or shortness of breath. So they are not unaffected either. And it's really concerning because we are starting to see that younger age group now as well in the hospital. Certainly in less proportions than normal, than the higher age, but we are seeing it.
Yeah, and I think it's really important to note that, and remember, the coronavirus is still out there. It still is coming after us, and you just have to read the headlines every day or see what's going on. Colleges are beginning to shut down again for the fall. We know that Harvard and Princeton have both decided they're going to only allow part of their students back on the campus in the spring and the other part in the fall and the other part in the spring. I know that all the schools around are beginning to have that same discussion, and we're going to go into those discussions with KU as well as other border region schools. We've been actively having those discussions. So this is very real, and the amazing part is, to me, that if we'll just remember, we did bend the curve once before with the shelter-in-place orders. And I think what we have to decide as a society is at what price full freedom. Now, I don't mean freedom as far as freedom of speech and things like that. It's really about the freedom of movement in this question. And we just have to think about what is the choice we want to make. Because we also know, on the flip side, there's really good news on the medical front. Regeneron is coming out with some new therapy that looks effective and going into phase 2 and 3 trials now. And the government has just announced a $100 billion investment into a startup vaccine that looks really promising. So there's a number of vaccine therapies that I think are going to be pretty effective. We just got to get there. And the way to get there is to socially distance, shelter in place, wear a mask, wash your hands, don't touch your face, cough into your elbow, and then don't go out if you're sick. I mean, those are the basic rules, right?
Right, absolutely.
Have they changed, by the way?
No, absolutely not. Other than the fact that people said, I won't wear a mask unless I'm sick, you don't always know when you're sick. You know, in some of the reviews, 30 to 40% of patients at that time were either asymptomatic and remained asymptomatic or were just pre-symptomatic. So, there is a growing body of really strong evidence in journals like The Lancet, in the CDC journal Emerging Infectious Diseases and Morbidity and Mortality Weekly Report. And their conclusions are to really stop the spread, you need the physical distancing, the mask wearing, and the hand hygiene. And so there is a good body of evidence there on the pure medical terms in ways to decrease the spread, and that's what we need to continue to do.
And the more we know about this, the more we know that surfaces are not the issue. It's really about those respirable particles we have that come out of our mouths and come out of our nose and land with others or get thrown around or even recirculated. And I think, especially when you have those close contacts, the amount of particles going directly to a person is a lot higher. Whereas if you're more fully distanced, those particles tend to move
Disperse
apart
and
and
drop.
disperse.
Yep.
So it's just really important to wear that mask. What we don't want to do is see such a surge that it forces hospitals to begin limiting their bed availability and not being able to take care of folks. Doug, when we did this before, it really created quite a hit to the health of this health system and to all hospitals. That really, I mean, you're involved in conversations around the country with stuff.
Yeah.
Talk to us a little bit about that.
Well, just as a backdrop, before the coronavirus crisis, hospitals' average operating margin was 1.7%, so it's pretty thin.
Pretty low. It's not.
thin.
We're down there with grocery store industry. We're not up there
So,
with.
so
the
you
drug
don't have a lot
performance.
of margin for error if something goes wrong. So then the coronavirus hit. From mid-March through the end of May, our lost revenue is about $120 million. That comes right off our bottom line because that was just revenue we anticipated, revenue we needed. During that time, we did get some grant funding of about $67 million, but still didn't fill the gap. We still had a gap there. We can, as we look forward, there's a lot of information. The American Hospital Association came out yesterday and said that they predicted hospitals in the U.S. would lose $325 billion in 2020. What's more alarming to me is they expect from July through December they'll lose another $125 billion because volumes will not come back to the pre-COVID
Which
stage.
is kind of what a lot of folks are seeing.
Yeah, and that's something that we've modeled and tried to figure out. The only way we'll get back is to build the volumes back up. I mean, what caused this is revenue dropped. We have to build it back up. But, as we look through this, it's hard to believe that we'll get back to 100% of our previous volume.
It is hard, and you would think that in the midst of COVID, people would be so sick they'd all be flocking to the hospital. But the reality is people are so afraid they don't come to the hospital.
Right.
And we know that folks are having strokes and heart attacks at home. Maybe part of it, you can say, well, I didn't really need that care. But I think the reality is the loss of employment, the loss of your time off because you need to be at work because you didn't make money, especially for frontline workers and people who don't have paid time off. Paid time off, we forget, can be a relative luxury compared to for a lot of folks. And because they lost insurance, they don't want to take PTO, and then there's fear. And so we know that volumes are down throughout the United States. We're actually fortunate our volumes aren't as down as most, but man, that's a pretty big hit to a lot of hospitals.
Right. As I've talked to other CFOs around the country and various health systems, most of them predict that it'll take 2 to 3 years to get back to where we were. I don't know. I hope it doesn't take us that long to get back.
Yeah.
As you know, we have plans to ramp things up. It's hard.
It is hard.
It's easier to slow it down than it is to build it back up.
That's a
And
lot
that's
easier to slow down.
But
stage
even
we're
on
in
the
now.
patient side, these patients need these surgeries. They may be quote unquote termed elective, but they
Right.
need their hernias repaired. They need their gallbladders out. They need their joints replaced. These are all very important for patient quality of life too.
It is.
You guys could address this better than I, but as I run into people I know that I've social distanced from, there are people that are afraid to come to hospitals, and I really think, I know it's probably intimidating seeing people in masks, but it's safer here than it is just
really
out on the
is.
streets or that video that you described in the Lake of the Ozarks.
Yeah. There's no playbook for a pandemic.
Right.
Not a modern one. I guess there's one from 1918 and 1919.
And I don't remember that one.
I don't remember that one either. Some have challenged that I should have been remembering it. But the truth is, and it didn't go particularly well, so it may not be the playbook we want to really read from, and things weren't great. And actually, we know the playbook. We know what the playbook says for trying to maintain a healthy environment, which is shelter in place, wear your mask, wash your hands, don't go out if you're sick, all the things we talk about. But for
One
hospitals,
of the
it's
things I
hard.
want to mention,
Please.
we talked about planning and what we might do going forward. The thing that concerns me is what you guys opened with today is we don't know, we thought we were over the hump and things were
Yeah.
getting better. Now I don't know. It's all that uncertainty. It's just hard to plan financially.
Uncertainty is I think one of the things that folks deal with or have the hardest time dealing with. And I know it's great to get out. I was outside last week, but I think that was the key. I was outside. I wasn't around a whole bunch of people. And in fact, I was around very few people. Fewer people than I'd be if I went to the grocery store, that's for darn sure. And so I think what we need to do is try to find activities that allow us to go out and be around people safely. You can do it safely, man. Those driveway dinners where people are way apart,
Yep.
I'd say go for that.
Yep.
That's great. Trying to sit around a crowded table or hanging out at the bar, may not be your best choice right now, unless you want coronavirus. If you want coronavirus, you go and do it, because it's not trying to be facetious about it, but that's how you get it. And so it's really, I think that's the key. Well, let's see if there's any media questions out there this morning before we turn to our listening audience. I don't think I'm hearing anything. I'm hearing a bit of a gurgle, but outside of a gurgle or a goggle or something, I don't know if it's a gurgle or goggle. Jill, what do we have?
Lots of questions already, and we
Oh.
thank the community for sending these in. Sherry has a multi-generational camp that she needs to go to. She says the food is going to be prepared outside and delivered, but those people are not being required to wear masks because the county is not requiring it and the health department is not requiring it, she said. And so she's wondering, she's not going to have any choice other than this food that's brought into the camp. And she wants to know your thoughts on it and things that you might do to protect herself.
Dan, I'm uncomfortable already.
Yeah.
If people aren't wearing masks in the camp, I'm assuming if the people who are preparing the food aren't wearing a mask and they're delivering the food aren't wearing a mask, then there's going to be particles on the things. And again, we don't think services are as bad, but I would be worried that if there's no requirement, that means at the camp, around each other, people
Yes.
won't be wearing masks. I think that's where you're going to get into trouble.
And I think that's the danger too. We don't want any communal food or utensils being used to scoop food onto plates. That doesn't sound like that's happening. But it's going to be hot now. I don't understand if this camp is going to be inside or outside. I would assume it's probably going to be inside most of the day. So you're in this small environment, no masks, close proximity to each other. And I think that's more the concerning thing.
And multi-generational, so there'll be people from different age groups there. And honestly, that's the setup for, that's a setup. Be careful.
Jean wants to know about new studies on aerosolization. Are you familiar with them, and what are your thoughts?
Yeah, I think we're both pretty
Yeah,
familiar with
yeah.
them. It's interesting. There was a letter, we talked a little bit about this yesterday, to the World Health Organization from, I think it was 284 scientists who wrote and said, gosh, we think you need to emphasize aerosolization of particles more and particles hanging in the air. There's a pretty big debate about what that statement really means, because when you delve into it, what it really was saying was that surfaces are not great, but air is the bigger concern, and really it's the droplets. And unfortunately we confuse these terms about what's aerosolized and what is a standard droplet. Aerosolized particles tend to be very small particles that hang around in the air for a very long period of time, and that's how tuberculosis can be spread, is how the measles was spread. Those are pretty rapidly spreading diseases. What we know about the coronavirus appears to be a little bit different. It doesn't really fit either of those other models very well. It kind of has its own thing going on. It acts more like the coronavirus or the common cold, which is you can cough, the droplets go out. The droplets still, they go into the air, so from that standpoint, they're aerosolized. But in a medical standpoint, that's a little bit of a misuse of the term. So if I cough and I breathe out, those particles leave my mouth, they leave my nose, they go out and around me. That's about a 6-foot radius. Most of them begin to fall off. And after that, the particles get dispersed around in the air, and especially if you're outside, because the wind currents and other features of what's going on in the atmosphere all the time just move the particles around. And it tends to make them a lot less dense. And by doing that, it makes them much less of a threat to you. In a room, however, the room flow and airflow isn't like that. So the particles can hang out a little bit more and a little bit longer. I think that's the concern. The answer to all this is a mask, because if you have a mask on, the particles don't go away from you. They stay in your mask. And that's what makes it so much safer to be in a room or to be around people with masks on. So that's where we really emphasize it. it is potentially true that those particles in a room without somebody with not wearing a mask may hang in the air for a little longer period of time because there's not wind, there's not other airflow to break it up. We don't know how long it really is, but we do know that beyond 6 feet and certainly beyond 10 feet, the size of the particles begins to get much more diminished, and they tend to be much more dispersed, and so you won't get as many particles when you inhale. It looks like the quantity of particles you inhale is related to some degree of your likelihood of getting the infection and how severe it is. It probably takes more than one. I don't know how many it takes. It probably takes more than one. So it really comes down to the same answer. People around you wear a mask and you stay safe, you're probably going to be safe. Dana.
Yeah, absolutely. I agree with everything. We also have indirect evidence from healthcare facilities of people just wearing masks. Again, aerosolized things like tuberculosis. We typically need a PAPR, which is a general
Kind of
higher
rolls
level
over you.
of
Yeah.
protection, or an N95 mask. I have never worn an N95 mask during COVID. We know that the virus can be detected on floors where there's no COVID. But those healthcare workers are not getting that disease. Those patients are not getting that disease. So, if it is aerosolized, to your point, it's probably extremely small concentrations, and eventually it's going to disperse. And is it going to be a high enough concentration to really cause infections? So,
Yeah, I
all
don't.
of that.
I think that's really the key. Otherwise, what we would see if all the respirable stuff was true, in terms about it being hanging in the air for so long, these small particles traveling hundreds of feet, then the infection rate would be much worse than it is. And it's bad now. It would be far, far worse if this was more like measles. So.
Olivia, she's concerned about getting health care back in more than 2 years, and she wants to know what is the fear there and what can public do to help? What do we need to do?
Doug, what do you think?
So to get healthcare back.
Well, you said that you didn't think that it might take 2 to 3 years to get health care back to the same level.
To
They're
the
concerned
previous
about
volumes,
losing.
the previous volumes.
Yeah.
I don't think people need to be concerned about that. I think we have plans in place. We are going to be financially viable. We're not only looking at revenue increases, we're looking at what do we do to control expenses. One of the concerns I would have if I was just general public is, are there enough people and staff and trained workers in the hospital to take care of me? We made a decision, probably going against the tide, not to furlough staff. That's a highly trained group of people that we need to keep them in place, and I think that's going to help us get back to where we need to be. So I'm even though I'm cautiously optimistic, I am optimistic about things. So I don't think people need to be concerned. I think, as Dr. Hawkinson points out, if you've got some issues, you need to be seen, need to come to the hospital. Telemedicine's a great tool. So I think that's really going to expand.
I do too. I think,
To that.
Well, it's the fear that you and I have talked about so many times. It's one thing if your margin is, like a pharmaceutical and it averages 18% of the year.
Right.
If you have a drop of margin of 5%, okay, it's not a great year, but you can handle that. For us and academics and in most hospitals, the margins just aren't that good. And people think that there's all this money in healthcare. Well, healthcare is expensive, but I promise you it's not in hospitals as far as making the money for it. And if you just look around at the average margin of hospitals, you would see that. And so I think when we lose money, the government comes in, they give us some loans, or some grant money, that's great. They gave us loans to help as well, but that loan is really a payment on Medicare that we still.
Advance payment.
Yeah, that's a thing we pay back, so that's going to be a bit of a struggle. But I'm with you. I don't think we're going to be closing. Well, I think some hospitals will close with this. I do think that's a real risk in the United States, and we're already seeing it in some smaller towns and smaller hospitals that had a really difficult time before.
Yeah, I think that's a place where telemedicine can come.
Yeah, they
help
can.
fill that gap.
But it's going to be a bit of a slog, and just as it is for the average American, we're no different than the average American in this regard, right? If you're worried about your job and your income, that's what hospitals are worried about too. We're going to work our best to make sure we take great care of folks. What we know is that our hospital census is back up. It's not as high as it was prior to COVID. It can't be as high as COVID because we eliminated all of our semi-private rooms because of risk of infection control, which means we lost 45 beds. And that's the right thing to do. But it is something we have to pay attention to all the time. We've got a lot of ideas in place to try and improve things. And I think we'll be able to hit that. But our job is to make sure we take great care of you.
Leanne says, husband and wife test positive at the same time. Should they socially distance inside their house, or does it increase the
That's
viral
a
load
great
if they're
question,
together?
Dana. That's a great question.
Yeah.
What about people trading the virus back and forth?
Yeah, I don't think there's any evidence that I'm aware of that there are adverse outcomes when patients are living together and they've both tested positive for the virus. You just basically want to self-isolate with yourselves in your house. Again, not going out, do all those measures that you would take if just one, but I think you can do that safely in your own facility, in your own household.
Yeah, I think that's right. I think maybe trying to avoid a ton of secretion exchange is a good thing. But
Yeah.
but beyond that, I don't think we really know. And
Right.
I think we're just trying to use practical, make common sense. But I think if you're both positive and if you can stay a little further apart so you're not constantly breathing on each other, that's probably good.
Joyce is going to have work done at her home for 3 days. She's going to be gone. The workers are going to be unmasked. She wants to know how long before I can come back to my house safely.
Yeah, it's probably pretty soon.
Yeah.
The stuff on the particle, again, on the surfaces looks less and less important. But
Right.
anyway, 6 or 8 hours, I think it'll be fine.
Yeah, I agree with that. Just a few hours is going to be fine. Let any particles that may be in the air drop to the floor or other surfaces. When you get home, depending where they work, you want to maybe clean the high-touch horizontal surfaces. But other than that, I think you'd be fine to return.
Yeah.
All right, a lot of people asking about, some of them are high risk. Loretta's one. Several people asking about going to the dentist, and is it safe to do it with the increased spread that's out there? One person's wanting to know, is it safe to have your wisdom teeth pulled out?
Those are great questions because there is a much higher rate of spread. A lot more people are getting this, and it continues to escalate because we haven't. You know, it is a sadness to me that we don't take mask wearing very seriously in the United States, and it's become so politicized. And I'm like, how could something so basic to healthcare become a political symbol of freedom when what we're really talking about is your freedom from disease and health? And, you know, masks make the difference. It just, again, I've used this example a couple of times, so I'll have to use it one more time, I guess. You wouldn't want your surgeons to be unmasked when you're in the operating room opening you up. Why would you want to walk up with somebody who doesn't have a mask on? It just, you know, it kind of confounds me. It's like we want to act like the virus doesn't exist when it exists everywhere.
It's there, yeah.
I think as far as going to the dentist, Dana, I think it's about making sure the dentist has a mask on. And I promise you, the dentist will have a mask on.
Yep.
And I think you can get your wisdom teeth done safely. Again, what we know, a really great anecdote was the two hairdressers in Springfield who were around people for 20 minutes to 2 hours who didn't have a mask on, and both were had a mask on. Both those hairdressers were positive, but because they wore masks, how many people got infected out of the 140 that were seen? And the answer is zero. I think that's the story. So if you go to the dentist, I think you're good to go. I think you just have to wear a mask. They have to wear a mask, you have to wear a mask.
That industry, and we've talked about this, the dental industry, ENT physicians, neurosurgeons are some of the highest risk groups, and certainly I believe the dental industry has been very vigilant in making the utmost precautions. Obviously, you're going to be wearing a mask when you go in. You have to get the mask off when they're working on your teeth, but more than likely, and you can call ahead and see what their procedures are, everybody in that facility is going to be wearing, at minimum, a surgical mask, if not an N95, just because of the close proximity that they're working with you in. So goggles and N95s, and I believe most all facilities have made it as safe as possible, but you're welcome to call ahead and ask what their procedures are.
Similar question about mammograms. Safe to go and get them?
Yeah, I think it is safe to go and get a mammogram. And I think, once again, it's all about wearing the mask and making sure that you do that. Pick your favorite team. My wife went out and ordered for me some Chiefs masks. By the way, Patrick Mahomes, let's go. I'm ready. But wear those masks, and I think you can be pretty safe. I think you're really safe to get your mammogram done.
Terry's asking, any consideration again for limiting elective surgeries?
Great question, Terry. Yeah, actually there is. And we've had that conversation based upon bed capacity. In fact, we've been in contact with Wyandotte County. What I can tell you right now is we still have bad capacity, so I am not concerned. It may come to a point, if we get up to 40 or 50 or 60 inpatients, that we have to have that conversation again. That has occurred in Texas, as you probably know, in Dallas and Austin and in Houston and in San Antonio. Not throughout the state of Texas, but in the major metropolitan areas where the bed capacity has been pushed to the limit again. And I think if we see that, that's something we'd have to consider. Right now, I don't believe that it's necessary because we have capacity. Dana, what are your thoughts?
Yeah, absolutely. We have hopefully, and we have been, building up our stores of PPE, building up our stores of important drugs for people that are on the ventilator, in critical illness, and even those undergoing surgery. So right now, I think we are all good. That is one thing we look at daily. When do we stop elective surgeries and things of that nature? But right now, we are confident that we continue to have all of those supplies and the surplus that we need. But certainly that can change within a matter of a few days.
Doug, it would be pretty hard for us financially to stop it. I know we would do the right thing and stop it, but hopefully we won't have to do that.
Yeah, hopefully not. I mean, I agree with what you say. I think we're much better prepared if something happens than we were, 2 or 3 months ago. So
Yeah. We've learned a lot.
not something to look forward to, but I think we're much better prepared.
Yeah. So our plans right now are to keep doing elective surgeries because we think we can do them, we know we can do them safely. But we also know that we have to keep a careful eye out. We work with KDHE, Wyandotte County, Johnson County, and other healthcare leaders around the area to have those conversations.
Keston's asking, can you tell us how much you've received in federal grants and
We
how
can.
that has impacted your bottom line? How'd you spend the money?
We received here in the metro about $67 million in federal grants, which has obviously been a great help. As I mentioned earlier, during that same time frame, our revenue lost was about $120 million. So it didn't even cover the revenue loss, but it did help. How did we use that? It was just daily operations, and we spent money on testing equipment. We've tested lots of patients, not only here but around the city. PPE that Dr. Hawkinson mentioned, we really stocked up. So we invested a lot just to treat those patients. So I think we used it wisely. We also made sure that we kept the staff in place because we had to have these trained people to take care of our patients. So that's basically what we did with the funds.
And Doug, how much do we get that would be considered a prepayment on Medicare?
In the metro here, we got about $165 million, which is just an advance payment on Medicare. We'll have to pay that back.
So beginning
starting
in
this fall,
August, right, we don't get paid on Medicare until we've paid back the whole
That's
$167
right.
million. And we project it's going to take us 9 months to do that.
Right.
So it's a loan. It is not a grant. And some of you say, well, maybe we're going to excuse that. I don't think there's a lot of appetite for trying
I don't want to plan that we won't have to pay back.
Yeah, I think we're gonna have to pay
funds,
that
I
one
think.
back,
And that's
so.
in our plans. We've anticipated how that's going to work.
Yeah, it's, this is a hard ride for everybody, and whether you're in healthcare or, you're employed at home or in a job, and you talk to people all around. So many folks haven't been in the office for months, and these are hard times, and we don't want to minimize the hard times.
Somebody asked me yesterday, are you happy you got this grant funding of $67 million? And, I guess my response is I'm not happy about it because of the situation we're in, but we're grateful that we got it because it's really helped us.
Yeah, and it is been able to help us keep people employed and
Right.
help us keep on taking care of folks.
Mary Lee from Skidmore, and I'm a Barnard girl, so hi neighbor. She wants to know, some say that wear a mask when you can't distance. Others say wear a mask even if you are distancing. Is one a substitute for the other?
Dana, let's talk about this, because what we know is that distancing is the number one thing you do.
Yes.
And the second most powerful thing you do is wear a mask. And the two together
Yes.
are even more powerful.
Right. And combine that with hand hygiene. I think that matters really. Where are you? If you are outdoors, are you out at Loose Park or another park like that? Or are you indoors at a restaurant or shopping? I think the environment that you're in really matters. Again, we haven't really advocated for masks outdoors if you're exercising or walking or just hanging out, unless you're in close proximity to other people. But certainly we have advocated if you are indoors or in those other confined environments.
Yeah, I think if you're outside around a lot of folks, continue to keep a mask on. Now, here's my true confession. I'm out fly fishing last week. I was not wearing a mask when I was fly fishing, but I was out in the middle of nowhere, and there weren't a lot of folks around. When I take a walk in Loose Park in the morning, I don't wear a mask. But if I see somebody coming, I walk at least 20 feet around them.
Yes.
And there's plenty of space to go at 6 a.m. because there's not a lot of people in the park.
No.
Myself and a few others, and my wife maybe, and my dog. But I'll tell you what, in the evening in Loose Park, that is a different story. And I would have a mask on then because it's just too hard to get away from all the folks.
Yeah.
So you just have to be thoughtful and make good, sound decisions. And if you do that with the guidance we give you consistently, and I think, then I think you can really do a pretty good job of staying safe.
Yeah.
This one's a philosophical question, I believe, but Elena says that there's a doctor on Facebook, and this doctor is telling people that our system is broken, that it's really more sick care than health care, as doctors get paid on procedures and that's in doing testing. And she wants to know, he wants everybody to share this video and talk with their health care and their government. What do you think about all that?
That's a much bigger question than a COVID question. That's a question of, is healthcare right to be paid for the work that you do, as opposed to be saying, okay, I'm going to try and keep you healthy as a panel of patients, which is kind of the Kaiser Permanente approach in HMO. And there is certainly a lot of evidence that suggests Kaiser is a great system and works really well around that. I also think you have to go look up the data around different health systems, because what you'll find is there is marked variation between one place and another place and how many procedures are being done per capita per 100,000. And if you start getting into the information, you'll find there are a whole lot of differences around that. What I can tell you is that we look really carefully at how well we do relative to how others do. And we know that our patients have some of the best outcomes in the United States, because we compare ourselves with the top places in the country. And in doing that, that's why we're on the U.S. News and World Report. And more importantly to us is the Vizient ranking, because that's a much more ranking of real medical stuff and not just reputation points. And when you start looking at that, we're consistently one of the top 20 academic hospitals out of the 200 or 120, whatever the number is, hospitals in the United States. And to do that, you look at how much it costs per person, you look at how many procedures are being done, and what the outcomes of patients are. And ultimately, if your outcomes are better, or especially much better than what you expect, then you have to ask yourself, I'm probably not doing too much stuff to people, because we know that when you do too many things to people, because that's how you get paid a lot more money, outcomes go down, because they have complications, and that makes things worse, not better. So I think there are a lot of, again, this is a great question. It gets to the fundamentals of healthcare more than COVID. But I think you can figure that out as a consumer by going and trying to do a little reconnaissance and finding the information about how hospitals stack up in terms of the outcomes of their patients. And what we know is that historically, in some areas where there have been a lot of usage of procedures, patients actually do worse. And so if you focus on patient outcome, you can figure out pretty fast who's doing the right thing around people.
Allie wants to know if you can help explain the difference between capacity and beds. What do you mean when you're saying that?
Yeah. So we can both take a crack at this one.
Go for it.
So there's the number of hospital beds you have, and that is part of what determines your capacity. There are other things, how many operating rooms you have, because some people get to go home on the same day, so number of beds isn't as big of a deal. But what we run into is this problem, where you have to ask yourself, what are the challenges if you get overwhelmed from COVID? Where do you get the bottleneck? The real bottleneck is in a couple of places. It can be in general hospital beds, but we have 800 hospital beds. We're not going to run out of hospital beds, I don't think. It's in ICU beds and the number of ventilators you have that you can run into trouble. And that's where folks ran into trouble in New York. It's where they're running into trouble in Houston. It's where they ran into trouble in Seattle. And what happens if you don't have enough ICU beds and you don't have enough ventilators, then you have to start putting patients who are on life support in beds that may not have all the right monitoring, and then you're just trying to fly a little bit by the seat of your pants, and then that's a little riskier. And when you really run out of beds, you run out of ventilators, then somebody's got to stand there and use a bag, or what we call an ambu bag, to try and help people ventilate. That hasn't happened too much in the United States. It did happen a number of times in China and another area in Italy. It did happen a little bit in New York. But really, it's the real question for us is, what's our capacity like in terms of ICU beds and ventilators? What we've done as a result of the first wave, we created a whole plan around that. If we close down operating rooms, we can convert OR machines into ventilators. We can take them away from some of the smaller surgery centers around that are part of our health system. There are a lot of plans we have in place to do. We actually had all those done, and we had done all that stuff the first time around. Unfortunately, we didn't have the wave because, people did a great job here in Kansas City, and they sheltered in place, and they did the things they need to do. So I don't think we're in danger of that right now. It's possible if the surge goes off and if people don't act responsibly that we could end up back there again. That is truly possible. Fortunately, nursing homes are doing a lot better job around infection control, so we're not getting the same number of patients in from the nursing homes. But if a lot of people get this disease all at once, that could create a problem with capacity, even more than the number of hospital beds. It's our ability to make sure we have the right equipment for folks. We're fine
The only
now, though.
thing I would add to that is part of what determines capacity isn't just beds, it's how long the patients are in the hospital.
That's right.
If that
100%.
length of stay lengthens, that obviously limits over a year your capacity to treat patients. And that's something we watch. And
It is, and Dana, I tried to get you to
Can't
say this
predict it,
yesterday, and you were so darn good, and I can think, because I'm, Mr. Pollyanna, I look at the world sometimes a little bit of rose-colored glasses, and I
Yeah,
feel
you
like
have those
that-
on today. It
I
looks
have
like
them
you
on
do.
today, I do. I even have this kind of light-colored
Yeah,
pink
it is.
shirt, and that's like a rose-colored shirt,
Yeah.
so I'm going to be Mr. Optimist. I think that therapy does make a difference for
Yeah.
folks. I think we're
Yeah.
doing better than
Absolutely.
Our ventilator strategies are better.
Mhm.
I think the steroids have helped folks.
Yeah.
I think anticoagulations help folks.
Yeah.
I think remdesivir have helped folks. I think convalescent serum and plasma has helped folks. So it feels like we've got an array of weapons we didn't
Yes.
have the first wave.
Yeah, absolutely. Not optimal, but it's the drugs that we do have. And it's also the time when we give them. Dr. Barr, Dr. Salate, our whole therapeutics group has worked hard to get the latest, most up-to-date information and adjust our algorithms for treatment as you can. I know if I were diagnosed and I met the clinical criteria, I'd absolutely want remdesivir, serum, dexamethasone. And on the other point about capacity, our own Dr. Castro here has been working with community hospitals as well around the Kansas City community so that we are all coordinated as a team should that surge or should that further wave of infections and critical illness come as well. So we've been involved not only with us, but other health partners around the city.
Yeah, I'll tell you, the work that we've all been able to do as chief medical officers or infectious disease docs or administration and CEOs with our hospital colleagues around Kansas City has been outstanding.
One thing
Been a
that strikes
great
me, and I'm like the non-clinician here, so I probably shouldn't speak, but it's amazing to me how much progress it appears that we've made in a short period of time, just with all these things.
Yeah.
So I think people need to feel confident that healthcare is in good shape.
We were trying to do some math last week. I'm going to come back at it again.
This is
Would-
dangerous.
It is dangerous when Steve does math. That's true. I'm looking for my footstool so I can rest my feet on it. It'll be a little. It always makes me smarter to have my footstool. Back in January, the virus has been in the United States probably since December and maybe prior to that, because it clearly was in Wuhan in October, and people started traveling internationally. So it looks like certainly by January, probably in December, it's been here. People started talking about a vaccine. They said it's going to take 12 to 18 months. And people started on that vaccine in December and January, because even though it may not have been fully in the United States, people all over the healthcare experts and the folks who do with the World Health Organization and the CDC and others think, let's get this vaccine thing going. They were starting to gear up. They got the genome. So they said 12 to 18 months. That means next January. That could be. And again, there's this thing about this. Was it Novolog? Was that what is
Novavax or something like
Novavax
that,
is the
maybe.
company that is producing one of the vaccines and just got $100 billion from the government for vaccine production. They're producing 100 million doses of a vaccine that hasn't even been approved yet, because we think it's going to work.
Yeah.
And there are a couple more of those like that.
Yep.
So the real key is we got to get to January. We're halfway there, folks. We're halfway there. You're more than halfway there. So just think about it. I know you want to go back outside. I know you not want to shelter. I know you want to be normal in life. We're not normal. We're just not normal yet. You just have to accept that. But you also ought to say, we're halfway there. We can do this. BKC, we can do it.
I think the NIH has been really proactive. They have several irons in the fire and partnering with corporate partners with funding and rapid trials, again, looking at efficacy and safety. And so hopefully that in the next coming months, 6, 7, 8, 10 months, there will be something out there that we can use and is viable and does protect against infection or even severity of infection as well.
And I've read that, and I know there are a number of people who are against vaccines, and that's a right of folks to make that choice. I will tell you, we'll require of everybody in our workforce to get vaccinated, because we just can't let people come in the hospital and have healthcare workers making them sick. That's just not acceptable. And so that'll be a requirement from our perspective. Which we do with influenza vaccine already, right? Unless there's some reason that folks don't have, that they can't take it, they have a bad reaction to it, or there's some other problem. But I think you'll see that around the country, and I don't think that's going to be unique to KU. I'm pretty sure that everybody's going to have the same approach. I'll tell you what, I promise when that vaccine comes out, I'm going to be in line. My arm's going to be right there. I'm saying right here, because it's what keeps us safe at this kind of time. And vaccination is safe, and the reality is all we're doing is giving you pieces of the virus as if you had been infected, and your body's immune system produces those things that it takes to try and fend off that infection. And we know that they work. We know that they reduce the severity of an infection. They can help keep you safe.
So Christina has maybe, I don't know if you want to be wrapping or not, but she has a two-part question. The first part's probably for Dr. Pollyanna.
Okay, I'm here.
And the second part is probably for the IB guy. Do we think coronavirus will ever go away? And then the infectious disease part might be, how do we eradicate it? If you can list.
Okay.
Yeah.
Well, I think we
Those
could
are
probably
easy
both
questions.
use this
Yes.
answer, because the reality is
Yeah.
coronavirus is going to be here, and coronavirus is here.
Yep.
The question is, will this mutation go away? And what we know about coronavirus is it tends to mutate from year to year. So at some point, the things that are making this coronavirus more dangerous may mutate. But that's not a strategy. That's a hope. And what we need are strategies. Because sitting around and waiting for coronavirus to mutate and not become as serious as it is today is hopeful. And I think that could well happen. But it's a hope. Flip side is, it can mutate into something worse too. So the reality is, you have to try and practice the same things that we know keep you safe, Dana.
Yeah, absolutely. You know, there doesn't appear to be any clinical difference, any clinically different strain that was in Wuhan. There may be some other mutations. You know, there's still interesting points about the spike protein and infectivity. We are looking at that. We understand that the other coronaviruses, the 4 other coronaviruses that jumped species, that cause common cough and cold, mild illness, you know, again, they jump species anywhere from 100 or 500 years ago to 1,000 years ago, and those are still here. So I think moving forward, we would love to be wrong, but we have to assume that it probably will be here. And will we be able to eradicate it? Certainly by vaccination, we would hope so. Certainly by direct acting antiviral medications, we would hope so. But there's still a lot of research and strides that need to be made on that front.
And I think it's also safe to say that we need to examine our practices together around the world about what causes things to jump from one species to another. What's going on in our environment that seems to be a bigger problem today than it used to be.
Right. We have an excellent sentinel area or tip of the spear, you know, in China, in Wuhan, that was doing really good work on researching these viruses. Their funding has been cut. They haven't been doing it as much, but we do have people on the front lines who are out there every day looking for new viruses and threats and trying to announce to, you know, World Health, whether that's the CDC or the World Health Organization, what are these threats and how do we combat them the best?
Doug, final thoughts today. Are we safe as a health system?
I can't speak clinically, but financially I think we're safe. I don't have the same set of glasses you have, but I'm optimistic.
Dana, final thoughts today?
Yeah, I think we have talked about our patients coming here, you know, come here, get your health care. We have always advocated for, as one of the questions was, preventive health. We have always advocated for that. But even before COVID, we saw that people weren't getting primary care doctors. They were just coming to the emergency department. And we certainly advocate for people to seek out medical teams or primary care doctors to help with that preventive things. Blood pressure medications, cholesterol, cancer screenings. We know that we are still doing elective surgeries. We will continue to do surgeries, but we have to remember it's a pretty high trauma season right now. There are a lot of car wrecks. There's other traumas. And so in order to continue doing those things as well, we need blood supplies. So, while you still can, the CBC, the Community Blood Center, is very safe to go donate blood. Please go donate blood and blood products. And if you think you've recovered from COVID, call them, talk with them. Maybe you can also donate convalescent plasma as well to help other people who now come down with COVID.
Steve, the only other thing I would mention, and this goes with your rose-colored glasses, there can be good things that come out of a crisis
Yeah.
like this, and the way people pull together and make things work, and I think that's where we are.
I think so too. Well, as we wrap up today, a few things. First, tomorrow we are going to talk more about preparing for a surge. Dr. Sean Coomer, who is the VP of Perioperative Procedural Services and an outstanding liver transplant surgeon here, is going to talk about talking about what are we going to do around a second wave. Also, we have some photos on the way out. Debbie, who is telling us from Florida, she's retired from KU. Wanted to show her support for KU Colors in the hospital, and Nancy, who's on her way back to Kansas City from North Carolina, on a plane and all masked up and with goggles. Well done. That's what I would look like if I was on the plane too. Yeah. Continue to show us how you're staying safe. Send some of those photos to the web address there, www.medicalnewsnetwork.org. You can't stay safe. And just remember that you've done it before. And you did it by following the basic rules of infection control that are here with us right now. So let's keep each other safe, because I want to see Patrick Mahomes play for the next 10 or 12 or 14 years here in Kansas City. I think we're going to win some more Super Bowls, and that would be awesome. Yep. So let's go Chiefs. Let's go Royals. But remember, there's still no place like home. We'll see you tomorrow.